Okay. Hello, everyone, and welcome to today's webinar for mental health professionals, how to best understand and address selective mutism in younger children, tweens, and teens with Shelley Abney. Sorry. My name is Astra Masfar. I am the Senior Coordinator for Education and Outreach here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio panel, and the dial-in information will be displayed. Please make sure you are muted during the entire presentation and your webcam is disabled. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat box of the control panel. You may send in your questions at any time, and we will collect these and address them during the Q&A session at the very end. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation, and the link to the evaluation will be sent to each participant within 48 hours of this webinar. The post-test assessment will occur at the end of the presentation. The questions will appear on your screen, and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Shelley Abney. Shelley Abney is a clinical psychologist in private practice in Manhattan with expertise in assessing and treating anxiety disorders in children and adolescents. Before starting her own practice, Dr. Abney was the director of the Selective Mutism program at Kurtz Psychology, where she founded We Speak, an intensive behavioral group intervention for tweens and teens with selective mutism. The We Speak program was featured in an episode of BBC World News as an illustration of the struggles faced by tweens and teens with selective mutism, and how We Speak addresses these difficulties. Dr. Abney is a frequent presenter at ABCT, ADAA, and the Selective Mutism Association, serves on the ABCT website editorial board, and is on the ADAA and ABCT program committees. Dr. Abney is invested in optimizing treatment outcomes for children and adolescents with anxiety disorders and uses the integration of theory, practice, and data to guide her in these efforts. I'm now going to take a moment to pass the screen to our expert. There will be a brief pause while I do so. All right, Shelley, the floor is yours.
All right, there we go. Thank you so much for that introduction. And I want to thank ADAA for giving me this platform to talk about selective mutism. One of the reasons that I actually got involved in selective mutism is because it can so frequently be misunderstood or misrepresented. And so I am happy to have this opportunity to be able to reach a large audience of varied professionals with different areas of expertise to disseminate some of the information that we have in our small SM world and share some of the work that we've been doing. All right. So you can all see my PowerPoint. All right, so I wanted to just put this page up as an acknowledgement to those who have helped in the development of We Speak. So I'll be talking much more about We Speak later, but these are all individuals who have contributed to that development in a very significant way. And I just wanted to add that I have nothing to disclose. For this presentation, I'm going to start off with an overview of selective mutism and then discuss some of the empirically supported treatments for SM, then talk a little bit about the developmental limitations in those existing treatments, and then introduce We Speak, the intensive behavioral group intervention for tweens and teens with SM. Then I'm going to talk about some of the developmental adaptations that were made for the development of We Speak. Then I'll present on some outcome data from We Speak, and then I'll talk a little bit about conclusions and future directions and for questions. All right, so for those of you who are a little bit less familiar with selective mutism, selective mutism is an anxiety disorder that consists of a consistent failure to speak in specific situations in which speaking is expected, like at school, despite speaking in other situations. So these are kids who can talk, who do talk, and are actually often described as chatterboxes at home. And when they are in uncomfortable settings, which often is in school or with people who are less comfortable to them, they are unable to generate a verbal response when prompted. In thinking about how impaired these kids are, I want you guys to imagine for a second being a 6-year-old and being in school at age 6 and sitting in the classroom, and the kid next to you turns to you and says, "What's your name?" You want to answer, you want to make friends, you really want to talk to this kid, and you go to say your name and nothing comes out. The teacher calls on you and says, what letter comes after E? You know the letter that comes after E, you want to participate, and you go to say it and nothing comes out. Imagine yourself at home when you're age 6, in your comfortable setting, and your parents invite over a friend, and you are not even able to talk to your parents in front of your parents' friend, even though it's in your comfortable setting. Those are just a few examples of how selective mutism impacts these kids, and this is what they experience all day, every day. Kids with selective mutism have a hard time making friends. They have a hard time participating in class. They have a hard time even telling the person at the ice cream store what flavor ice cream they want. And they might even not be able to speak in their comfortable settings if other people are around. So it's a very impairing diagnosis, and these kids are really suffering. I want to take some time to dispel some of the common myths among professionals who, and educators, and even parents actually, who may be less well versed in selective mutism. So one of these is that kids with selective mutism are being defiant or oppositional or are choosing not to talk. This is because kids with selective mutism are in such a long ingrained pattern of avoidance and have really learned to navigate their world by using nonverbal communication. And because they are avoiding these anxiety-provoking situations, they oftentimes don't look anxious. And this is not the case when they are expected to talk or when they are prompted. They feel very anxious, but a lot of the time people around them will remove those prompts because they know that they're not going to get a response, and that's why it can tend to look like they are choosing not to talk. They also can tend, in uncomfortable settings, to look like kids who are autistic. So these kids are not making eye contact, they're not interacting with other kids, they're not talking. And these are some of the same symptoms that we see in kids with autism. If you look at these kids at home, they look nothing like kids with autism. And that's why it is so important to be able to understand their presentation in their more comfortable settings so that you can make that very clear distinction. I also wanted to mention the shyness factor, because a lot of these kids are described as shy, and there's a difference between shyness and selective mutism. Shyness is a temperament, and one that doesn't need to be addressed, one that is not interfering. It's just one that is a kid's personality. Selective mutism is a disorder that, in the ways that I mentioned before, really impacts these kids' lives and is not part of their personality, but rather a significant anxiety that is stopping them from living their lives in the way that they want to be. The last thing is that there are some misconceptions around selective mutism being caused by trauma. So that's not to say that there are not cases of comorbid selective mutism and and PTSD, or a kid having experienced trauma, but certainly there's no causal effect there. All right. The etiology of selective mutism is not dissimilar from the etiology of other anxiety disorders. So there is an interaction between genetics and the environment. And in terms of the genetic component, there is oftentimes parents of kids who have selective mutism who also have an anxiety disorder themselves, and particularly social phobia or even a history of selective mutism. We also see that kids with selective mutism have a very long history from very early on in life of being behaviorally inhibited, and this persists over the course of their childhood, has been linked to other anxiety disorders. In terms of the environment, I want to highlight two different factors here. The more important one being parents, because they play such a significant role in this interaction between genes and the environment. So if we have parents who are already anxious themselves, they are likely going to be modeling that anxiety for their kids and rescuing their kids from anxiety-provoking situations when they see that their kids are in distress and they have the best intentions, but they have a hard time tolerating that distress, and will then inadvertently send the message to their kids that these situations are not safe and that their kids can't handle these situations. So that feeds back into this cycle. There also is some research to show that kids who are immigrants may also be more likely to develop selective mutism. And this is because of factors such as acculturation, language acquisition, and potentially even peer rejection. And so more research needs to be done on that. But at this point, the research that does exist suggests a higher level of SM in immigrants. And then the last one is neurodevelopment. So kids with selective mutism also have higher rates of speech and language problems, general delays, and social deficits. And if you think about these various factors, we know that any one of them would likely make a kid more anxious. And so all three of these risk factors interact with each other, and then taken together will then create a more likely chance of the kid developing anxiety. And as we know from anxiety, the inclination when we feel anxious is to avoid, and so then we end up seeing a cycle of avoidance from these risk factors. All right, due to the low prevalence rate of selective mutism, which varies depending on what study you're reading, but on average, it's about 0.7 to 0.8% of the population has selective mutism, and the estimates go up to about 1%. Which is still pretty low compared to other anxiety disorders. And so there hasn't been as much research in the area of selective mutism as some of the other anxiety disorders. What there has been has shown that there are promising results for kids with selective mutism. And I just want to highlight a few studies that are noteworthy that have been done. One is Vecchio and Kearney from 2009, and they did an alternating design comparing child-focused exposure-based practice with parent-focused contingency management. And they found stronger effects, not surprisingly, for child-focused exposure-based practice. Bergman and colleagues in 2013 did the first randomized controlled trial for selective mutism using integrated behavioral therapy, which is essentially CBT, and that involved the child, the parent, and the teacher. And they found that 75% of the of the kids in the integrated behavioral therapy group were deemed treatment responders. None from the waitlist were, and these gains were maintained 3 months post-treatment. And Auerbach and colleagues in 2014 did a study comparing defocused communication plus behavioral techniques. And so I'll go into each of those separately. Defocused communication involves joint attention around shared pleasurable activity, which for kids with selective mutism is a great way of getting them comfortable and warming them up, because it removes the focus off of the one-on-one conversation aspect of the interaction. And so it helps them get comfortable when there's less pressure to be talking directly to the person. The behavioral techniques consisted of exposure and stimulus fading. Stimulus fading in the SM world means an unfamiliar adult or an adult who the child is not talking to, or a peer that the child is not talking to, getting closer and closer and closer gradually as the child with selective mutism is speaking to a familiar adult. And this happens until the new adult is with the child and the familiar adult, hears the child talk to the familiar adult a number of times, and then eventually uses very basic prompts to get the child to talk to them. So that was compared to waitlist control, and this group found significantly increased speech in school in the treatment group, and not in the waitlist group. All right, so behavioral group intensives have been shown to be effective and are actually increasingly preferred for a number of reasons. First, it allows accessibility to families with limited treatment access who are able to travel to a specialist or someone who has expertise in the area in which they are struggling, and receive a high concentrated dose of treatment over a short period of time. It also allows for social interaction with peers, which in diagnoses like social phobia and selective mutism is obviously very helpful practice. It also helps to decrease the stigma around these diagnoses. And we have actually been told in our groups that we run for selective mutism that these kids, prior to coming to the group, really felt like they were alone and felt like they were crazy or there was something wrong with them, and that they were the only ones suffering with this. And by being around other kids who are struggling with the same issues, it really helps to normalize those problems for them and accept working on those problems. And along the same lines, it provides an opportunity for all the kids to model for each other the experience of approaching the feared stimuli, which helps to build kind of this shared motivation in really challenging themselves. So Dr. Stephen Kurtz took this behavioral group intensive model and adapted it to the selective mutism population for kids ages 3 to 9. The model uses a 1-to-1 ratio of counselor to kid, so that the counselors are trained in selective mutism and the strategies that are used, and with the kids one-on-one throughout the day to help scaffold and shape their goals that they are working on. And it's all behavioral and exposure based. And this model has shown positive results in speaking in school and in public settings. Because school is one of the main domains in which selective mutism manifests and is most pronounced, it's really important to work with the school in treatment and do this work before the treatment, after the treatment, and on an ongoing basis so that the school is able to implement the strategies that are effective in these group settings. It's also important for parents to be trained so that they can help these kids carry forward the strategies and skills that they have learned. And so Schwartz and colleagues have recommended a multidisciplinary approach that includes treatment for the child, working with the school in terms of collaboration and consultation, and parent training. All right, so this model that I've been describing is very effective for these kids in the 3 to 9 age range. However, most of the studies and treatments that I described really are limited to kids 9 and under. And there is a subset of the selective mutism population who is older than age 9, who until recently really were not receiving treatment and didn't have the resources to be able to help them. We know that that there are these older kids with selective mutism. One of the reasons for that is because there is a lag time typically because of the years that pass between the symptom onset and treatment referral. And this occurs because parents and pediatricians and educators and even mental health professionals who may not be as well versed in selective mutism might expect that these symptoms
Shelly, your audio went out. Shelly, sorry.
And this makes sense because these patterns of avoidance are less ingrained in the younger kids.
Hi, sorry to interrupt. I think you might have to repeat the last 30 seconds of your presentation. Your audio went out for a little bit.
Oh, okay.
Yeah. Okay. Thank you.
Thank you for letting me know. So I was just talking about the developmental limitations of the current models in that most studies include just kids who are 9 and younger, and there are a subset of the SM population who are older than age 9, and one of the reasons for this is because there's often a lag time between symptom onset and treatment referral. And this is because oftentimes parents might be waiting for the symptoms to pass or for the kids to grow out of it. So kids might not end up getting treatment or starting treatment until they're older. And so Orbach, who I mentioned in one of the last slides, found in their study that younger kids actually did better in their treatment outcomes than older kids in his sample. And this makes sense because these patterns of avoidance are less ingrained in the younger kids, making it easier to treat. But this also suggests that this treatment model that has been used for these younger kids may not be as conducive to the older kids. All right, so there are some developmental differences in clinical presentation between younger kids and older kids, and I can speak to this both anecdotally and from a research perspective. So anecdotally, what we've seen are a few pretty significant differences between older kids with a history of selective mutism and younger kids. Older kids are actually more generally responsive in that they've learned to give the minimum in their responsive, especially to get their needs met. And so they're able to give one word responses when asked a question. Whereas with these younger kids, it's a little bit more rigid in that they have people that they absolutely don't talk to, and under no circumstance can they talk to them. And so it's a little bit more fluid with these older kids. We've also found that and this is not going to be surprising, that the older kids are just much more impaired socially than the younger kids. While the younger kids are not necessarily talking to peers, they are able to engage non-verbally with peers. They are able to still make friends when they're younger, but when they're older, they really struggle much more in terms of their social relationships. And the third factor that we've seen as a difference between the two age groups is in motivation, in that the older kids are less motivated to receive treatment, just given the developmental point that they are in life of wanting more independence, wanting to make their own decisions, not wanting to be forced to come to therapy, and having less self-reflection, or the ability to self-reflect and recognize their impairments. In terms of the research, there have been some studies that have looked at the trajectory of selective mutism over time, and selective mutism can follow two different paths. One, for the more severe kids, their path can often be that their symptoms persist and their selective mutism continues into adolescence and adulthood. And for the kids who are more moderate or mild, their course might be a little different in that the core symptoms of SM, so the talking itself, may remit. However, other difficulties are present and emerge and become more significant over time. And this is really particularly seen with social phobia and other phobias. So this group needs to be looked at as well and considered even when their core SM symptoms subside, because there are still definitely residual effects from their history of selective mutism. So in both of these cases, there is an extensive history of avoidance and reinforcement, making this older group more resistant to treatment. And I mentioned before that treatment also is just more difficult because there's this long history of limited social interactions where these kids haven't had the opportunity to practice their social skills with peers in not having talked to peers and form those social connections. And then there are fewer peer relationship opportunities because at the point where they are older, as I mentioned, kids have already formed their own friendships. And so even when they are ready to practice and want to make new friends, those kids might not be there and ready to reciprocate. So because of all of these differences, then it's obviously important to consider these differences when planning treatment and developing a treatment. And there is literature to support the need for developmentally appropriate treatments for anxious adolescents, separate from treatment for younger kids with anxiety. Additional treatment approaches that have been recommended include motivational strategies, cognitive restructuring, and social skills training. Another area that needs to be considered with these older kids is addressing comorbidities and persistent problems beyond the core SM symptoms as they get older. As I mentioned, there are other problems that equally, if not more problematic than the core SM symptoms. So we want to focus on the individual as a whole in the treatment that we're doing and not just treat them for their SM. As they get older, it's also more important to include them in treatment and have them participate in planning and goal setting, which helps with their motivation. And finally, another consideration needs to be in how to promote generalization with these older kids. When they're younger, it's much easier for parents to schedule play dates and go to the school, and for the school to be more heavily involved. When they're older, they have multiple teachers, a lot of kids in the class, and so the treatment and the multidisciplinary strategy needs to account for those different variables. So when I really dove into the field of selective mutism, I started seeing a couple older kids and really enjoyed my work with them. And I was able to use these strategies, these behavioral strategies, to help them make progress in them talking to adults and them talking to unfamiliar people and them talking to their parents in front of other people and them ordering in restaurants. But at the same time, I wasn't able to address the most critical factor and the most critical area of impairment, which is their peer relationships. So I decided that it was really important, and there was a really high need to adapt this model for younger kids to an older group of kids with SM or a history of SM. And thus I created We Speak, which is an empirically informed intensive group intervention for older youth with SM between the ages of 10 and 15. And I've run 5 cohorts of We Speak since 2016. And the results of We Speak and the program components have been presented at ABCT, ADAA, and the Selective Mutism Association. We Speak really aims to simulate a school setting based on the academic and social demands of older kids. So in running We Speak, I try to build in every single opportunity that they encounter on a daily basis in school and in their social world at this age, in their preteen and teen age, and incorporate that into the treatment that we're doing. And I try to make it as close as possible to their experiences in school, so that it will be more likely to generalize. It uses the same one-on-one model that builds continuous and individualized practice into engaging real-world activities. And we call the one-to-one mentors instead of counselors, just because that seems to sound cooler to older kids. And so the mentors work with the kids to, again, help them meet their goals one step at a time each day of the program. So this is for the developmental limitations that I mentioned earlier of the treatment models for the younger kids, and it also accounts for the unique challenges of selective mutism that require techniques beyond CBT for child anxiety. So for most of the treatments for child anxiety, it involves the kids coming in, even in a group setting, the kids coming in, saying their name. The cognitive restructuring involves verbalization of their anxious thoughts and some coping thoughts. Developing a hierarchy involves them being able to articulate situations that are difficult for them and they want to include in their hierarchy. And none of this would be possible for a kid with SM. And so the model itself needs to be adapted for this specific population. All right, so some key factors of We Speak that I want to highlight are, one, the interpersonal style that's used in We Speak with the teens. So I just, and I'm gonna combine this with the next point of motivation, because they go hand in hand in that if you want a teen to get on board with treatment, especially something like this where it's going to be an intensive model, it's going to probably involve them traveling to an unfamiliar place. They're already anxious and they feel like they don't need it, and it's easier to continue with their pattern of avoidance. It requires a certain style to lure them in and to get them on board. So this is something I presented on motivation at last weekend, actually, at the Selective Mutism conference. And in terms of the interpersonal style, with teens, you want to be able to find the balance where you are engaging with them over shared interests. And so before we speak, I get a very long and comprehensive list of all of their interests and hobbies and activities that they participate in, and all of their favorites, including YouTube channels and favorite apps and favorite card games. And this is what we use as a baseline to really engage with them. At the same time, we can't begin with an SM kid by asking them questions. And so the style that we're using is in talking to them about some of the interests that they have without asking any questions, sharing some of the links that you have with them in your interests, and then using that to get them more interested in working with you. You also want to be careful, in addition to not asking questions in the beginning, but at the same time engaging them and talking to them, you want to be careful to find that balance where you're treating them like an adolescent because they don't want to be treated like a child. So that style is important to use with them, where you're joking with them and using more advanced language, but also at the same time not being too intense in the style that you're using or too over the top with enthusiasm, knowing that one, they're adolescents, and two, they are kids with anxiety. So the other key factor, having tied interpersonal style and motivation together, is that we want to simulate their real world as much as possible. And so I do a lot of research from kids, from parents, from teachers, to learn the activities that they are doing in school, the different classes that the kids are taking, and what the structure of the activities are, so that I can incorporate all of that into We Speak. And then the key overarching factor for all of this is that I try to be as systematic as possible. These are kids who are very sensitive to challenges and are very sensitive to any small changes in variables. And because of that, if they feel overwhelmed, if they feel like we're pushing them too hard, then they're going to be likely to shut down. And because of that, we have to make sure that we are going step by step by step in steps that are manageable to them. One of the ways that I do motivate them is by telling them that, and if there's something that feels too overwhelming to them, then I will take it upon myself to scale it back, and that I never want to overwhelm them. And so they know that going into the program and understand how systematic this process is, which allows me to get a little bit more buy-in from them. In terms of the preparation for We Speak, I do an ATIS with the parents as a diagnostic interview, and this is so I can be aware of all of the comorbidities that I want to work on and that the parents want to work on. And this brings me to the next item of establishing goals. I give the parents and the kids a goal sheet and have them fill it out together and check off all of the goals that they want addressed in We Speak, and then identify their top 3 goals. And there's room for them to write goals outside of the SM domain, so that, again, we're not just focusing on those core symptoms, but we're focusing on the individual as a whole. To help with motivation, I do what I call video prep sessions. Video prep sessions are very brief video sessions, about 10 to 15 minutes, that occur over 3 to 4 total sessions. And the goal is, one, to help build motivation to participate in the program, and two, to ensure a verbal response prior to the intensive. So the last thing that I would want to happen would be these kids and families showing up for We Speak and they are not able to become verbal. They go the entire week without verbalizing and they get nothing out of the intensive after they have paid a nice chunk of change for it and invested a lot of time into it. So I want to make sure at the minimum that they will be able to verbalize, and we do this over a couple prep sessions. The first one where the teen is not asked any questions and not expected to speak at all, and then they have the opportunity between the first session and the second session to come up with a question that they want asked of them in the second session, and to come up with the way that they want the question asked and the way that they want to answer the question. So they're given options to have me ask the question, have their parent ask the question, to turn their head to answer the question, to whisper in the parent's ear. And this is all an example to them of small steps that we take forward so they could see that they are manageable. And yet at the same time, we are then eliciting ultimately that verbal response at the end. I also work to hype up the program in these prep sessions. I joke a lot with their parents so that they can see that that I can be fun and at the very least non-threatening. And then I will connect one or some of the in We Speak to a primary interest of theirs, because I always try to create activities based on the interests of the kids who are coming in. We also have lead-in sessions, which are 1 to 4 days before We Speak, depending on severity. And I want you to imagine the rationale for the lead-in sessions. I want you to imagine kids with selective mutism, a high level of social anxiety, coming into a new city, an unfamiliar setting, all new adults, all new kids. And if we were to start day 1 of We Speak and just jump right into our activities, it would not be pretty. So we really want them to be able to get comfortable in this new environment with the adults, with me, and around the other kids, at least talking around the other kids before We Speak, so that during We Speak, we can work on those higher level goals of maintaining conversations, initiating conversations, and participating in class and some of the other issues that they are struggling with. All right, so I'm going to go over some of the components of We Speak. Every day we have advisory meetings and debriefs. The advisory meetings are with each kid and their mentor separately for about 5 to 7 minutes. Where they meet with me and they discuss, we discuss together their progress from the previous day, their goals for the day, and how their mentor is going to help them in meeting those goals that day. I was telling people last weekend, actually, at the conference, that the advisory meetings are, even though they are brief, they're incredibly powerful because these kids are older and they have the capacity to be collaborative in the goal setting and to understand what their goals are and to understand how to work on their goals. And you can oftentimes, without even knowing what their goal is, you can, as an observer, identify what they're working on because they're so direct in targeting their goals for the day. We also do debriefs at the end of the day, and this is done with their mentor, where they review successes and challenges from the day. They receive their homework assignment, and they're given 2 homework assignments each day of We Speak. I'm the one who assigns the homework, and one of the homework assignments is a We Speak assignment that involves them connecting in one way or another with someone else from the program, whether it is texting, whether it's going for ice cream together, whether it's just kind of planning for their get together the next day. So that will be assigned, and then they're also assigned a homework assignment, which connects something that we did that day or something that they're practicing to a situation back home that will then link those two. So this could be texting with someone from school, FaceTiming with someone from school, posting something on Instagram, commenting on someone else's post. And then at the end of the debrief, they meet with their parents and share their debrief form with their parents. These two, the advisory meetings and the debriefs, are really a great way to promote collaboration and transparency with these kids who, again, really want that autonomy, want to be recognized as adolescents who are emerging adults, and this gives them ownership in that process. We also do a skill of the day, and so these are empirically supported anxiety skills adapted for the SM population for the lower demands for verbal participation. So we do anxiety identification, developing a hierarchy, relaxation, and cognitive restructuring. And as I mentioned before, these are activities that in the typical anxiety protocols require verbalization. And so when we do them in We Speak, there are lower demands for verbal participation in that we still want them to be thinking about these skills and generating their own ideas. And at the same time, we know that the verbalizing is going to be hard for them. So we adapt it so that there's less pressure and less of a demand to verbalize and even generate their own ideas. And so they're given for each of these a menu of options to choose from. And I can show you an example of that in a minute. We also do social skills training for a couple of the days as our skill of the day. And we do one day on imperfection and messing up as our skill of the day, where the entire day, starting with the morning lesson, is focused on messing up and practicing that and seeing that that's okay. So these are examples of hierarchies that that we did for these kids. Based on my intake with the parents, I created a number of situations that I knew were relevant to the kids based on what they are individually struggling with. And then the kids picked out the ones that were particularly relevant to them, showed the full range of easy to hard, and then put them in order on these hierarchies. And that is used to guide the homework during We Speak and their ongoing goals. We also have academic specials classes and to simulate all aspects of school, including class participation, partner and group work, asking questions, physical engagement, rotation of teachers, and group and class presentations. We do have specials teachers aside from the main teacher, who is myself, and this is to practice having a variety of teachers and getting verbal with a variety of teachers. And again, everything that we do within each of these goals is done very systematically. So class participation starts off very easy, where they're given the answer and given the question, and then over the course of the week, it gets harder and less certain. I want to show you guys this video.
To let you know that it is 12:51, so we want to give participants some time to ask questions at the end.
Got it. We're ending about 5 minutes late, you said?
A little after 1.
Okay, got it. All right, so I'll show you.
Say this name, or you're gonna need help saying it. How do you say it? Awesome, telling us. Okay. And does she have tall buildings where she lives, or she doesn't?
So you could see how inhibited these kids are. And I want you to remember those kids as I show you another clip. This is an example of a partner project that we have them do in every We Speak. The partner project is always different, but we want them to get practice in working with kids outside of school or outside of We Speak on a project, which requires a lot of different skills that these kids may not have yet developed and may not have yet practiced. So we have them practice asking a peer to be their partner, exchanging contact information, planning meetups, collaborative planning and problem solving, sharing opinions, taking initiative, doing a joint presentation, and making decisions. So the partner project is something that they work on throughout the week, both in and out of We Speak, and it culminates in a presentation together in front of the class at the end. And this is a girl who is reading the children's storybook that they wrote together. I'm going to skip over this. This is just a presentation of these two actually reading their story that they wrote together. And it is both of their first times presenting in front of a group and even actually talking to adults associated with school.
All right, this is our book called
All right, so we do social exposures the second half of the day, and this is broken down into unstructured conversation practice, which is really incorporated into activity. Lunch is obviously very difficult for these kids as it involves completely unstructured conversation and being able to use those higher level conversational skills. So this is a social exposure that we did at Chipotle, and you could see the kids here sitting at a table and carrying a conversation themselves, which none of them have ever done. And we started off more involved in helping facilitate the conversation and then slowly backed off until they were able to independently do so. I also, for the first time, did a school social event in the last We Speak, which I had them come back in the evening, and it simulated something like a school dance or like a Halloween party or a Valentine's Day party to get them practice in those situations as well. And we also do some structured social practice through social skills and a scavenger hunt that involves them being in teams and asking various adults questions as part of a competition. All right, so this is the same group of kids. This is the same group of kids that you saw before. At the end of, this is the last activity at the end of the week, and you could just see the difference in their inhibition over the course of the week. This was our bowling social exposure. So they look like typical kids, and that is exactly the goal of the program. Just the last few slides here. So obviously we need to adapt some of the parent and school collaborations and education for these older kids. For parents, we really want to emphasize validation and collaboration, really including their kids in the process, and also being able to understand their kids' struggles and pull back sometimes from them continuously pushing their kids, as well-intentioned as they are. And we want to be able to help them, help parents, help their kids with peers in a developmentally appropriate manner, knowing that they can't really facilitate play dates in the same way. And we want to talk to them about how to be an advocate for their child with the school. With the school, we want to provide education around selective mutism in older kids and those differences that I talked about. We want to find a point person who can really help with the goal setting and be that point of contact for the kid in the school in helping them follow those goals, and brainstorm with the schools what outlets there are for social interaction and adult facilitation. Just to show you guys some of the outcomes from We Speak, this is our winter cohort. So we have baseline 1 month and 6 months. This is not a randomized trial, so there's no control group. So it's just pre to post based on the sample that we had. The SMQ was developed for young, and so it's not a measure that really is conducive to the older group, but we're seeing here that there are improvements that are steady over time. And something that we found is that the social domain for these older kids is really the most impaired. A lower score on the SMQ is worse. And so the social domain at baseline is consistently the area that is most challenging for them. This is a self-report that I created so that the kids have an opportunity to report on their own experiences. This is pre 1 month and 6 months for each case. And you can see, again, a steady incline in their scores. There are quantitative scores about how many kids they text with, how many kids they hang out with, how often they're raising their hand in class in each of those domains, but items that are more appropriate for adolescents. And there's only one kid here who went down, and that is really based on increased awareness around her level of impairment. In terms of conclusions and future directions, we know that knowledge about and resources for youth with SM has really advanced tremendously in the last decade, but there's been a lag in addressing the needs of older youth with a history of SM because the course of SM is not well understood. This is a very heterogeneous population with a variety of comorbidities, and the symptoms closely mirror those of social phobia, and so it's not entirely clear at this point how to tease those apart. We also know that behavioral group intensives developmentally adapted from models for younger kids have shown promising results in verbal behaviors, and in the future we want to try to work more on disseminating this information and having this treatment more accessible to others, being able to address the comorbidities, continuing care after the intensive to promote generalization, and doing more longitudinal studies to really best understand the course of selective mutism with and without treatment. All right, so I would love to answer any questions. Thank you guys so much for listening to the presentation, and I have here the documentary in case you are interested in watching that. Oh, there's my cat who is jumping on the desk right now. So in case you want to watch the documentary, I have the information here, and then I have my contact information as well.
Thank you so much, Dr. Avni. We're now going to begin answering questions. I actually do have a few. All right,
great.
So we have one, are any of the homework posting or sending videos or audios of themselves speaking on Snapchat or some other social media app and directing those to peers, fellow students and teachers and others adults back at home? Sorry, let me.
Can you repeat that?
Sorry, I'm going to go ahead and just send you a chat of it.
Okay.
Posting. Oh, directing those to peers, fellow students, and teachers or others adults back home. Did you receive it?
I did not. Oh, here. I think I need to open the chat box. There we go.
Yeah.
Okay. Yes, so they are all actually directed toward peers, fellow students, sometimes teachers, and other adults back at home, depending on their hierarchy and their areas of impairment. Their homework might be to Snapchat a peer from home, but it is addressing those very relevant relationships step by step. So for kids who haven't talked to their teachers, it might involve making a video for their teachers. So it's all related to those real world situations at home.
Thank you. And we also have another question. I think this is more of a request, but I will just send it to you anyways.
Okay. Do you want me to read it aloud so everyone can hear it?
Yeah, sure.
Okay, I treat SM. I've had great success recently getting a 4-year-old with SM to talk to strange peers and adults, as well as peers and adults at preschool after she had never done so before. I know SM is not due to trauma, but I interacted with a fellow psychologist recently who forcefully insisted that SM in this particular child must be due to trauma because SM is always due to trauma. I wanted to refer him to a peer-reviewed publication that compared the prevalence of a trauma history in kids with and without SM, and I did not know of a good article. Can you please provide a citation to an article that provides data that rebuts this myth? I can, if you can actually give me, actually what I can do is maybe post it on the ADA listserv afterwards, so that everyone can have access to that.
Yep, I can include it in the post email after the webinar as well.
Yeah,
like.
that's a great request though, because as I mentioned, that really is a common misconception. And as much as we can, we really want to dispel those myths. So I really appreciate you making such a strong effort in doing so.
Awesome. And we have one more question. Would you universally recommend medication for kids with SM in this age group, age 10 to 15?
That's a great question. I would say I wouldn't go as far as saying universally, but I would go as far as saying that it is the rule rather than the exception. I think it would be an exception for kids to be able to successfully address the SM and other comorbidities without medication. At this point, it's been ingrained for so long, and it is just their anxiety has just grown and grown and grown over the years. And in almost all the cases that I've seen, medication has been necessary to complement the therapy. But I will say that I have seen a couple cases where the medication actually wasn't needed. And these are cases with without comorbidities. So when there are comorbidities, then the medication is almost always indicated.
All right, I think that is our last question. Thank you so much, Dr. Avni.
Thank you. Thank you, everyone.
And thank you, everyone, for participating in today's webinar. For those seeking CE credits, the post-test assessment will be distributed after these few announcements. I'm actually just going to skip for time's sake. All right. You will now have the opportunity to complete the post-test assessment. You must have registered for this webinar with CE credit, obtain a minimum 80% or higher on the post-test assessment, and complete the webinar evaluation with the provided 4-letter code in order to be eligible for CE. If you do not receive a score of 80% or higher, please email webinars@ada.org. And if you would like to arrange to do this post-test assessment at a later date and time, you can email webinars@ada.org. I will now launch the post-test assessment.